Hi guys, welcome back. Today we're going to talk about atrial fibrillation. So first of all, let's define what atrial fibrillation is. So atrial fibrillation is a type of supraventricular tachyarrhythmia. So supraventricular because the origin of the arrhythmia happens above the ventricles, supraventricular, and in this case it starts in the atria. It's tachyarrhythmia because it's a fast rhythm, irregular heartbeat, but I will talk about the different types of AFib in a bit, and we will see that there are actually some that are with slow ventricular rates, and some that has fast ventricular rates. But just in general, it's a type of supraventricular tachyarrhythmia, and it's usually because of multiple irritable foci or reentrant circuits that fire, generating this really irregular heartbeat. Okay, so that's what AFib is. So let's first talk about the causes or like the risk factors for atrial fibrillation. So we have two main subgroups. So we have cardiac causes or cardiac risk factors. So these are the ones that are intrinsic to the heart. So there's a problem within the heart itself. And the second group is the non-cardiac causes. So these are things that can cause AFib that's not because of a problem in the heart itself. Okay, so let's first talk about the cardiac causes or the cardiac risk factors. So one of them can be because of like the stretching of the myocardium, the stretching of the atria. So we can see this in things like dilated cardiomyopathies or like in congestive heart failure. So in these conditions, what happens is the myocardium gets really stretched out, including the atria, and that change in morphology can trigger a reentrant circuit or irritable foci to develop and therefore trigger atrial fibrillation. The second one can be because of ischemia or low oxygen perfusion to the myocardium. So if a certain part of the myocardium, a certain part of the atria gets starved of oxygen, the cells, they undergo remodeling. And during this remodeling process, that changes the morphology of these tissues. It causes some irritability. It may even trigger formation of reentrant circuits, triggering atrial fibrillation. Just to mention some of the examples that may lead to ischemia. So we can have like coronary artery disease or a MI that leads to ischemia and sometimes even to infarction of the tissue, again leading to that remodeling, which may trigger atrial fibrillation. The third one can be because of valvular diseases. So the most common one that can lead to AFib is mitral stenosis. So in mitral stenosis, we have a really stiff stenotic mitral valve, really narrowed, like stiff, calcified, doesn't want to open, basically. So what happens is that the left atrium needs to get bigger to be able to push through that higher pressure valve, because it's really stiff, it's really difficult to open. So the atria needs to get bigger so that it can contract more to push through that stenotic valve. So it stretches, it gets bigger, and again, this remodeling process can trigger some irritability or some reentrant circuits to form in the atria. Mitral regurgitation can lead to this to some extent as well, but it's less common. So in mitral regurg, we have like really floppy mitral valves. So every time the atria contracts, some of the blood flows back to the atria. So this means that, the atria has to accumulate more and more volume, and therefore it stretches out. Again, that remodeling process can lead to formation of some ectopic foci or like reentrant circuits in the atria. The fourth potential cardiac cause can be because of inflammation. So for instance, if someone has like rheumatic fever, which can lead to rheumatic heart disease, they can develop inflammation of the myocardium and of the valves. So this can lead to mitral stenosis, which can lead to AFib, or just because of the fact that the myocardium is inflamed, that on its own can then trigger formation of multiple ectopic foci or reentrant circuit, triggering atrial fibrillation. The last one is hypertension. So if we have systemic hypertension, obviously the left ventricle needs to get bigger to push against that higher resistance, and at the same time, because the ventricle has gotten bigger, the pressure has increased, the atrium has to adapt as well. So the atrium also becomes bigger, hypertrophies, leading to remodeling, leading to formation of ectopic foci and reentrant circuits. So these are some of the cardiac causes. Now let's talk about some of the non-cardiac causes. So the first one can be pulmonary causes, like if someone has a COPD or like an acute PE. These could all lead to hypoxemia, and that low oxygen levels in the blood can make the atria irritable and trigger atrial fibrillation. The next one can be like pheochromocytoma. So in this scenario, what we have is a tumor in the adrenal medulla, which makes the the adrenal glands to just release lots and lots and lots of epinephrine and norepinephrine. So this leads to the heightened sympathetic nervous system activation, and that again can irritate the atria and lead to atrial fibrillation. So anything that increases sympathetic nervous system response can trigger irritable foci in the atria or reentrant circuits and cause AFib. So another example is hyperthyroidism. So again, similar mechanism, increase in sympathetic nervous system activation due to the increase of the beta-1 adrenergic receptors. They become more sensitive. We increase T3, T4. Again, these all increases our sympathetic nervous system activation. Another potential cause is when a person uses and abuses like cocaine or methamphetamines, because these are sympathomimetics, so they mimic the action of the sympathetic nervous system. So what they do is they bind to the epinephrine and norepinephrine receptors and activating those receptors. So we increase the activation of our sympathetic nervous system. So this too can trigger atrial fibrillation. The other one can be when someone is septic. So during septic shock, for instance, the patient gets really, really hypotensive. So the reflex reaction of our body is to increase sympathetic nervous system, right? To increase our blood pressure. So this too can lead to atrial fibrillation. The other one can be just, when someone has surgery, just the sheer stress post-op can increase our sympathetic nervous system activation. Another non-cardiac cause or risk factor for AFib is like electrolyte imbalances or abnormalities, especially if we have low potassium and low magnesium. This can alter the electrical activity in the heart. Sorry. So these are actually triggers for AFib. And another important one, which I almost forgot, is alcohol. So have you heard of the holiday heart syndrome? So when people go on holiday and they drink a lot of alcohol, like every single day, they do binge drinking. That can trigger atrial fibrillation for a known mechanism. We have hypotheses. So we can potentially get AFib from binge drinking because of lots and lots of alcohol, because alcohol actually can stimulate sympathetic nervous system as well. The second hypothesis is that drinking a lot of alcohol increases the production of reactive oxygen species in the body, and these can cause a lot of inflammation and then again trigger some irritability in the atria, can lead to atrial fibrillation. The other potential mechanism is maybe just because of vomiting, because when you drink a lot, you feel sick and you vomit a lot of things, including potassium and magnesium. So you actually deplete a lot of these electrolytes when you vomit. So that can also trigger atrial fibrillation. Just to summarize some of the mechanisms that can lead to atrial fibrillation. So atrial fibrillation, what happens is that we irritate some parts of the atria because of multiple things like stretching the atria or like inflammation or increased sympathetic nervous system activity, decrease in electrolytes such as like potassium and magnesium, and also like ischemia, the decreased oxygen supply in the myocardium. So all of these can trigger the atria and cause it to have like irritable foci and or reentrant circuits. And these ectopic foci and reentrant circuits, they interfere with the normal sinus pathway. So in normal sinus rhythm and ECG, we would see P waves. And in atrial fibrillation, we don't see these P waves because we've interfered with the normal sinus pathway. Also, this explains why in atrial fibrillation, we see an irregular rhythm. It's because we have multiple ectopic foci firing, or like multiple reentrant circuits firing, that all the impulses all go through the AV node in different from different areas of the atria, from different locations in the atria, and therefore we get that irregular rhythm, also with no P waves, because the impulses are not coming from the sinus node anymore. Also, the irregular rhythm in atrial fibrillation, as I said, due to those multiple ectopic foci firing, sending impulses to the AV node, transmitting that to the ventricles. This actually causes variations in heart rate. That's why we have different types of AFib. But if the rate is fast enough, the patients may feel symptoms like they may feel palpitations, they may feel fatigue, shortness of breath, or they may even have syncopal episodes. Like I said, we can have variations in heart rate. So we can either have really fast or slow heart rate. So either one is a big problem. Say, for example, a heart rate is greater than 150. So in such fast heart rates, what we're doing is we're not giving the ventricles enough time to fill. And if they don't have enough time to fill, we decrease the end diastolic volume, we decrease their preload for the next cycle, and then we decrease their cardiac output, we decrease their blood pressure, and we can put them into cardiogenic shock. So this is bad. At the same time, if the atrial contractions are slow, so if we have inadequate atrial contractions, recall that the blood goes from atria to the ventricles, and that process of blood filling from atria to the ventricles, 70 to 80% of that is passive. Like the atria doesn't have to do anything to fill the ventricles with blood, okay? The valves just have to open. And the remaining 20 to 30% of the blood gets transferred from the atria to the ventricles via that atrial kick, that atrial contraction. If we have inadequate atrial kick, then more blood stays in the atria. And this is bad because this causes stasis of the blood. So remember Virchow's triad. One of the components of Virchow's triad is stasis of the blood. So if we get stasis of the blood in the atria, then this increases the risk of forming clots. And those clots can break off and travel to the brain, causing a stroke, can travel to the kidney, causing a renal infarct, travel to the spleen, causing splenic infarct, travel to the gut, causes like some mesenteric infarct there. So by the way, the other components of Virchow's triad is hypercoagulable states and endothelial injury. The other one is stasis, which we have in this situation. Now let's discuss the classification of atrial fibrillation. So we can classify AFib in many different ways. So the first one is we can classify it based on ventricular rate. So we can have AFib with rapid ventricular rate. So this means that the heart rate is greater than 100. We can have AFib with slow ventricular rate, meaning the heart rate is less than 60. We can also classify it based on like hemodynamics. So we can have AFib, we can have like hemodynamically unstable atrial fibrillation. So if the patient has hemodynamically unstable AFib, it means that they have hypotension, pulmonary edema, altered mental status, and chest pain. If it's a hemodynamically stable AFib, means it doesn't have any of the above, doesn't have hypertension, doesn't have altered mental status, doesn't have pulmonary edema, doesn't have chest pain. We can also classify atrial fibrillation based on any involvement of the mitral valve or just valvular stuff. So we can have like valvular AFib. So valvular AFib means that there is mitral valve involvement or mechanical valve involvement. This is important because it helps us determine what kind of anticoagulation they would require. And then the other one is non-valvular AFib, which means that their AFib has no mitral valve involvement or no mechanical valve involvement. And finally, we can classify AFib based on its onset and like duration. So I don't think it's that important to remember all of this, but we have like new onset AFib, which means that it developed within 48 to 72 hours. We can have paroxysmal AFib. We can have long-standing, persistent, and permanent AFib. So I think it's just good to be aware that we have different classifications for atrial fibrillation based on these different factors. Let's move on to the diagnosis. So the first thing we need to order is an ECG. We all know what atrial fibrillation looks like. We will see no true P waves, just squiggly waves with the fibrillatory waves. That's characteristic of atrial fibrillation. And we are gonna see like irregular rhythm. So those are the things we're gonna see if it's atrial fibrillation. If there is, so the important leads to look at, by the way, are leads V1, 2, 3, and AVF. So those are the important leads to look at when looking for these things. If there is no AFib that we can see from the ECG, we need to look for evidence of potential causes that may, of potential risk factors that may lead to AFib. So for instance, we can look for signs of myocardial infarction or ischemia. So we can look for ST elevation and depression in the ECG because, like we said, ischemia to the myocardium can lead to the formation of these irritable foci and reentrant circuits, okay? So if we see evidence of ischemia or infarct, then, you know, we need to be alerted for potential atrial fibrillation. Even if we can't see it right then and there, it can develop. We can also look for evidence of like left ventricular hypertrophy. And if we don't see atrial fib right then and there, but their history or like the other risk factors are present, we can do continuous studies. So if it's done via outpatient, we can do outpatient continuous studies using a Holter monitor. If we do inpatient continuous studies, we can use telemetry. The other thing we can get is a chest x-ray. This is not diagnostic for atrial fib, but it's going to help us identify some of the risk factors, if they do have risk factors that may lead to atrial fibrillation. So what a chest x-ray can potentially show us, firstly, it can show us like pneumonia. You know, if we see consolidation of the lungs, pneumonia can, you know, it's an infection which can, you know, trigger some irritability in the atria and the myocardium. If we have COPD, we're gonna see the expansion of the lung, hyperinflation of the lung, and even maybe a flat diaphragm. And in COPD, we get hypoxemia, and this may irritate, you know, the atrial myocardium, again leading to AFib. The other thing we may see is like cardiomegaly, like a really big heart, and this may point towards congestive heart failure or dilated cardiomyopathies, which causes the stretching of the atrial myocardium, you know, altering its morphology, therefore potentially creating some irritable like foci there and some reentrant circuits leading to atrial fibrillation. So this is why it's still good to get a chest x-ray. Another thing we can get is an echo. So an echo is going to show us multiple things. It can potentially show us like atrial thrombus that can pop off and lodge into the brain, or like the like other circulations, like in the renal circulation, mesenteric circulation. So and this is because of the stasis of the blood, like I mentioned earlier. You know, when we have inadequate atrial kick, some of the blood, more blood stays in the atria, creating stasis, increasing our risk for forming thrombus. So it's good. So echo is going to help us identify if we have any atrial thrombus. The other thing that an echo can show us is like left ventricular hypertrophy. It can show us valvular problems like mitral stenosis, which can lead to atrial fib. It can help us measure like left ventricular ejection fraction. It can even show us if there's any atrial dilation, which means that, you know, we've changed the morphology of the atrial myocardium, which may be causing that irritation and the formation of the reentrant circuits in the atria. Now let's talk about the treatment. So I want to first describe the algorithm. as to how we treat someone with atrial fibrillation. So if someone comes with atrial fibrillation, the first thing we need to know is we need to determine if it's a hemodynamically stable or a hemodynamically unstable AFib. If it's hemodynamically unstable, meaning that they have pulmonary edema, they have chest pain, they have altered mental status and hypertension, what we do is we directly cardiovert them. We do a direct current cardioversion, okay? If they are hemodynamically stable, what we need to do is we need to give them medications for rate control. So we can give them like calcium channel blockers or beta blockers. I'll discuss this more in a bit later. So the main thing is that the desirable range is below 100 beats per minute for rate control. So after we've done that, we need to determine their need for anticoagulation. In 50 to 70% of the cases, these patients spontaneously cardiovert, so without using any electricity or any pharmacological agents, their heart rhythm just goes back to normal sinus rhythm within 24 hours. This is true for 50 to 7% of the patients. If they don't spontaneously cardiovert, then we need to consider cardioversion. For cardioversion, we can use electricity or we can use drugs called chemical cardioversion. And the need for cardioversion can be determined by assessing their risk for stroke and like how long they've been on AFib for. So for instance, if the patient has had AFib for less than 48 hours and they have a low risk for stroke, then we can cardiovert them. Okay, but if they have, if they've had AFib for more than 48 hours and they have a high risk for stroke, what we can do, we can order a TEE, so transesophageal echo. So we can order an echocardiogram to check if they have any atrial thrombus. Okay, if there is any atrial thrombus, we don't cardiovert. What we do is we give them oral anticoagulation for 3 weeks. And then after that 3 weeks, we recheck their TEE, check if the atrial thrombus is still there. If it's still there, then we need to put them back on oral anticoagulations for a bit longer, and then recheck if the thrombus is still there. If the atrial thrombus is not there, if it's not showing in the TEE, in the transesophageal echo, we can proceed on cardioversion. And once we've given them cardioversion, we need to determine the need for oral anticoagulation for 4+ weeks. I want to summarize that quickly. So the treatment algorithm for the treatment of atrial fibrillation. So when we have a patient with atrial fibrillation, the first step is to determine if they have a hemodynamically stable or hemodynamically unstable AFib. If they have a hemodynamically unstable AFib, meaning they have hypotension, altered mental status, pulmonary edema, or chest pain, we need to do direct current cardioversion. If they are hemodynamically stable, we proceed with rate control, trying to control the rate so that it's less than 100 beats per minute with different rate control agents like beta blockers or calcium channel blockers. Once we've done that, we need to determine their need for anticoagulation. Usually, 50 to 7% of the patients, they can spontaneously cardiovert to normal sinus rhythm without any electricity, without any drugs, okay, to help with this. If they have not spontaneously cardioverted, we need to consider the need for cardioversion, whether that's electrical or chemical. And we do this by assessing their risk for stroke and assessing how long they've had the AFib for. If they've had AFib for less than 48 hours and they are low risk for stroke, we can go on with cardioversion. If they've had AFib for longer than 48 hours and if they have high risk for stroke, we need to check if they have any atrial thrombus via a TEE, transesophageal echocardiogram. If there is atrial thrombus, we need to send them away with direct anticoagulation for 3 weeks. When they come back after those 3 weeks, we check their TE again, check for that atrial thrombus. If it's still there, again, give them another course of oral anticoagulation for a few more weeks. When they come back, we recheck their TEE, check for that atrial thrombus. If that thrombus disappears, what we need to do is we can then consider cardioverting the patients. After cardioversion, we need to determine their need for further anticoagulation for 4+ weeks because these patients are high risk for stroke. Okay, so that's the treatment algorithm. Now let's discuss some of these like treatments and medications in more detail. Some of the medications that we use for rate control include beta blockers. So beta blockers, for instance, metoprolol, it works by like blocking the AV nodes. So, there's multiple ectopic foci or reentrant circuits, and they're all firing. They're firing, sending impulses to the AV node, and the AV node conducts that to the ventricles. So beta blockers block that conduction, so it slows down the heart rate. It prevents all of those like impulses from getting through to the AV node and sending it all the way down to the ventricles. So that's how it works. The thing with beta blockers is that it's contraindicated for patients with like reactive airway disease, like COPD, for instance, because we have beta 2 receptors in our lungs, in our airways. And if we block those beta 2 receptors, then we may induce bronchoconstriction, and this might make their pulmonary condition worse. The next one is calcium channel blockers. So this blocks calcium entry into the myocardium. So this slows down the electrical conduction via the AV node. So that's how it slows down the heart rate. An example would be diltiazem. There's other examples, but this is the most common one used for AFib. And this is contraindicated for decompensated heart failure. Another one we can use is digoxin. So digoxin, as well as slowing down the heart rate, it actually increases the contractility. So let's focus on rate control. So we use digoxin in this case for rate control to slow down the heart rate, and it does this by stimulating cranial nerve 10, which is the vagus nerve. And when that's stimulated, that increases parasympathetic nervous system activity, and therefore slowing down the heart rate. The last one we can use is actually an antiarrhythmic. It's called amiodarone. So amiodarone works by blocking sodium and calcium entry into the myocardium, but it also has, interestingly enough, some beta blocker effect like properties. So it's good for rate control as well. The next one we need to discuss is rhythm control. So like I said, we can use medications or electricity. So if you use medications, we call this chemical cardioversion. So there's so many drugs we can use. So we can use antiarrhythmic drugs, and there's different types. There's like 1A, 1C, type 3 antiarrhythmics. So many ones that we need to name, but I'm not going to name them all. But just remember, we use antiarrhythmics in this case. And we need to be careful though, because using antiarrhythmics can prolong the QT interval, which can then increase the risk for having Kersatz de points. Okay, so this is a really scary ventricular arrhythmia. Okay, and it's potentially deadly, so we need to be careful using these antiarrhythmics. The next one is using electricity. So this is called electrical cardioversion. So we use electricity to try revert them back to normal sinus rhythm. The next thing is more of a long-term intervention. So to control their rhythm, their irregular rhythm, long-term, we can use radiofrequency ablation. So this is when we try burn like the ectopic foci or the reentrant circuits in the atria, so that it doesn't cause, it doesn't cause abnormal firing of those areas again. So we burn them off. We burn those areas off that's causing that's firing, that's interfering with the normal sinus pathway. So we call this radiofrequency ablation. The next one we need to talk about is anticoagulation. So like I said, we need to determine their need for anticoagulation, and we do this by comparing two different tools that we use to measure the risk. So we have the CHADS VASC score, which is it calculates the risk for stroke, okay, for clotting. And we need to compare that with their Hasbled score, which is a score determining the risk for bleeding. So we use these two scores to determine if they need anticoagulation. So if the benefit of being on anticoagulation outweighs the risk, which is bleeding, so if they have such high risk for strokes and not much of a risk for bleeding, then we can we should put them on anticoagulation. So if they score 0 on the CHADS-VASc score, we don't need any anticoagulation. If they score 1, then possibly we can give them anticoagulation. Again, we need to see if the benefits outweigh the risk using the Hasbled score as well, and based on their other risk factors. If they score 2 or more in the CHADS-VASc score, we definitely need to give them some anticoagulation. So the anticoagulants that we can use include warfarin, DOACs or direct oral anticoagulants, and heparin. Starting with warfarin. So warfarin is good for like valvular AFib. So AFib that involves the mitral valve or like mechanical valves. Okay, we tend to prefer warfarin for valvular AFib. Another thing for warfarin is that it's good for patients with like chronic kidney disease or liver problems. The problem with warfarin though is we need to monitor their INR. So if their INR should be between 2 and 3 ideally. If their INR is less than 2, then this means that they're still at risk of clotting. So we need to maybe up the dose a little bit. If their INR is greater than 3, then they are at risk for bleeding. So we need to maybe titrate this down a little bit. So again, INR should be between 2 and 3. Anything less than 2, there's the risk of clotting. If it's greater than 3, then they're at risk of bleeding. The second one is the DOAC. So DOACs, direct oral anticoagulants, we have 2 types. We can have the factor 10A inhibitors like apixaban and rivaroxaban. We can have factor 2A inhibitors like the bigatran. So these are used for non-valvular AFib. So AFib that doesn't involve the mitral valve or any mechanical valves. And the last one is heparin. So we have 2 types again. We have unfractionated heparin and we have low molecular weight heparin. So heparin is good like inpatient because it's very easily titratable. So we can, easily control the dose when we're in hospital. Another benefit of heparin is that it's good as a bridging therapy. So if someone needs to go on DOACs, then heparin can be used as a bridge. If someone needs to go through warfarin, then we can bridge them with heparin as well. Another thing that's good about heparin is that unfractionated heparin and low molecular weight heparin, they don't cross the placenta, so we can use this in pregnant patients. But I think low molecular weight heparin is preferred in pregnancy.